So we're going to switch gears now and talk about AI healthcare applications, safety net, and workforce. I would like to introduce our moderator, Stella Tran. She's the Senior Program Investment Officer for California Healthcare Foundation. Oops. Small emergency. It's okay. You can check out our bio, and I will let her do the rest of her talking. So she has as much time as possible.
You hope. Hi, everyone. So thank you, UC Irvine and the Center of Healthcare Management and Policy for having me today. I'm really honored to be able to introduce and moderate our panel today on AI, which you heard from the last panel is expected to solve all of our ills in healthcare. So I'm Stella Tran with the California Healthcare Foundation, where our mission is to improve access and quality of care for Californians with low incomes. And I work on our Innovation Fund team, where we're focused on technology issues in the safety net through impact investing and grant making. And so to introduce our panel today, I'd like to share a quick state of the union in AI, in healthcare, what's real, what's hype, and what's still unknown. AI is rapidly evolving, and each of us is only seeing one part of the transformation at any given time. And so I wanted to ground my presentation today with the perspective and lens that I am bringing, which comes from a few places. So first, through my work at CHCF, where we're focused on California's Medicaid program, or Medi-Cal, and the safety net healthcare delivery system. In the last few years, we've been working to support our providers and plans that serve the safety net to think about how can they implement and adopt AI. And finally, through the work of our impact investing, I have the opportunity to monitor market activity and see where venture-backed healthcare AI companies are going. And so, what's real? We know that healthcare organizations are adopting AI, and they're implementing AI at a faster rate than most technologies in the past. There was a recent McKinsey survey that found that 2/3 of respondents were actually actively implementing and experimenting and piloting with AI today. And we're seeing these changes in the buying behavior with procurement cycles massively compressed, particularly for health systems and outpatient providers. The primary use cases are in admin and revenue workflows, which reflects where venture funding has been concentrated. So if we look at the 8 healthcare unicorns that have raised over $1 billion in funding, they've been focused on clinical documentation, revenue cycle management, and payer operations. And we've seen this adoption pattern with our providers and plans in the safety net, particularly in clinical documentation. Our payers are progressing a little more gradually. Interestingly, their procurement timelines have actually expanded, but it could be that many of these payers had sort of activities in flight before this. But as more and more providers adopt revenue cycle or prior auth solutions, it suggests that there will be sort of this arms race between payers and payers will have to adopt to respond. And so in today's presentation, you'll have a chance to hear about real-world implementations from Dr. Kang Nguyen at Southern California Kaiser and Fawad Penguin, AI CEO. What else is real? So the AI capabilities and the infrastructure to support it are advancing rapidly, which can unlock efficiencies across a range of workflows. And I think we see a very feasible pathway to changing the cost structure of healthcare. And so, for example, we now have AI agents that can combine multiple LLM functionalities. So reasoning, what we see in ChatGPT and in some of these chat models, voice, vision, and computer use, the ability to use a browser or computer, and to support workflows like patient communication. So you have an AI agent now that can make 1,000 calls a minute, do it in a multitude of languages 24/7, hold memory of this conversation, and then actually document the conversation. And because of this agentic workflow, this requires new infrastructure. And so now we're seeing new methods for safety and quality assurance, such as AI testing AI, and interoperability layers to think about how do we integrate these agents into the current clinical systems that we have. So the technology isn't hype, but the hype could be, and I think we touched on this on the previous panels, could be the transformative the transformative impact on healthcare if we're not proactive about the desired outcomes we want to see. And so some open questions that I'm holding. One is on patient trust. Can we fully realize the ROI of any of these AI implementations if the users don't engage with these tools? Say you have an ambient scribing implementation and then patients opt out at scale. What does that mean for your system? On ROI, where does the value accrue? Will AI improve access, quality, and reduce burden for our workforce? Or will it just create new costs in the system and reinforce existing incentives? And today in session, we'll have Dr. Prabhjot Singh from the Peterson Health Tech Institute, where they've done some work to study ROI. We also think about payment and sustainability. How do we pay for these tools when there are costs associated with change management and implementation, when the costs of some of these tools exceed our current IT budgets? And how do we pay for them when they start off as an administrative cost, but then start to touch clinical? You know, we have examples of ambient scribing that can now support with clinical decision support. And finally, this is a debate I like to have, which is, are we in a bubble? When will it pop? And how do we know what investments to make amidst this uncertainty? So if we can look at the markets to tell us what's potentially next, they're optimistic, but they say there will be a correction, but not a full collapse. There's an emerging class of winners. These are the AI native companies, well capitalized, and continues to attract a significant amount of capital. And it reflects that they have high growth velocity, durable revenue, the ability to expand their platform and ROI. And the markets are making this bet that these companies will survive because they have real value grounded in robust business models. The markets are also making a bet on that the consumers will play a larger role. And we're seeing emerging trends in direct-to-consumer labs, cash pay, and concierge primary care. And I think and then we saw the new consumer-focused models launch from OpenAI and Anthropic. And I think it raises really interesting questions for our system because this increases the cost of patient acquisition when there's a new front door for care. And as more and more patients disengage with the formal healthcare system, how do we integrate what their experience is into our clinical care? And then finally on payment, there's some early signals that there are new models focused on digital and AI-enabled care, but more to come. And so Dr. Singh, again, will speak more about what is next. So despite these questions, I think it's really important for our system to implement to learn. I think it's really challenging to grapple with some of these questions around trust, value, governance, in theory and without a real implementation to work against. And so I really hope you come out of today's session with our panelists eager to explore and test more AI in your systems. And with that, I'd like to introduce our panelists. So we have Dr. Kang Nguyen, the Medical Director for Care Transformation at the Southern California Kaiser Permanente Medical Group, and Chief Medical Officer for Care Navigation at the Permanente Federation. He has been at Kaiser over 20 years, where he has grown from a staff physician to physician leader and leads initiatives to address the evolution in healthcare and consumer expectations. We have Fuad Butt, CEO of Penguin AI, an agentic AI platform focused on administrative efficiencies. He previously served as the Chief Data Officer at United Healthcare, Optum, and Kaiser, and was an executive in residence at Canvas Ventures, a venture firm with over $3 billion in assets under management. And finally, Dr. Prabhjot Singh, co-founder and CEO of Altitude and the senior advisor for strategic initiatives at the Peterson Center on Healthcare and Peterson Health Technology Institute. Most recently, he was Chief Medical Officer of CHW Care, which was acquired by Oak Street Health, now a part of CVS Health. And so thank you, everyone, and I will now hand it to Dr. Nguyen for his presentation.
All right, thank you, everyone. This is not the AI part, but I have to use reading glasses now because I'm a little bit advanced in age. So thank you very much for the opportunity to speak to this audience here. I spoke here last year, and so some of this is a little bit of an update on where we are with artificial intelligence, specifically within Kaiser Permanente, and specifically in Southern California, where I reside in practice. And the title of this slide is really Apply to AI in Medicine, Update and Use Cases, because we've actually made some pretty good progress in our current use of artificial intelligence. We were just asked the question, what is real? Everything that I'm going to present is real. It is in practice, and it is scaled or scaling. And we are talking to the tune of more than 10,000 clinicians and 4.9 million members. So as was stated, the AI has come a long, long way. So the first thing I want to bring back to you is this Gartner hype cycle. How many of you in the audience remember seeing this or saw this at some point, right? This is very interesting because my foray into AI started around 2022 and 2021, and I saw this curve which rapidly became kind of the industry standard of where AI was back in 2023. And that was really a year that marked really the beginning of the AI explosion, right? The AI hype. And you all may be guessing why it happened. Really, it was the onset of ChatGPT and generative AI. And generative AI is real simple. It's machines making stuff up to the best of their abilities, right? That's generative AI. And I actually had a really good discussion with someone earlier about generative AI. And I asked one question. I said, do you think that generative AI will give you the same answer every time? And the answer is no. So just think about that for a second. A machine will give you a different answer every time if you ask it the same question, okay? So in healthcare, that makes me as a physician very, very nervous, okay? So we rapidly saw the hype in healthcare and in AI in general. And then you see this, so it's the peak of inflated expectation, and then you get this trough of disillusionment. Like, oh my gosh, the AI is actually not going to be able to solve X, Y, and Z. It's hallucinating. It's telling people that it has stuff. And where do we go from here, right? It's the same thinking around autonomous driving. And I always tell everyone, I think I told this story last year, but I have a Tesla. I did buy the full self-driving. I'm not endorsing it. I love it, and I will never drive blindfolded, right? And so... just saying, right? So there are some guardrails and realities. So where are we at, right? So there was this disillusionment, and people are saying exactly what was said earlier. Where do we start using our artificial intelligence, okay? And the artificial intelligence that's out there. In the meantime, the industry kind of has gotten better. The IT, cloud services, agentic AI bots, people were beginning to put things together, right? And it became real. In other words, these are devices that you can really use. So I feel, as a person who is actually now guilty of AI applications and execution, we're at this curve now, the slope of enlightenment. And so what is that slope of enlightenment? That slope of enlightenment is, from an IT and technology perspective, there are more tools. Tools can do more. So what's the problem? The problem is what I hope to answer on the right side, okay? And that is, there are tools that are being developed. We're beginning to understand capabilities, but in our experience in Kaiser Permanente in Southern California, you've got to answer these questions. Because if you don't answer these questions on the right, then the AI tool doesn't make sense. It makes a bad process go faster. And in some cases, it can lead to a clinical decision that really you didn't really want, okay? And so really, it actually starts off with very simple things. Do you even know what your operational flow is? It's very simple. I ask a lot of my physicians, do you know how patients even come through our system, right? Like, who do they call, right? It's not Ghostbusters, right? I mean, they're sick, it's 8, like, what do they, and they're like, I'm not sure, like what people do. So if you don't understand your own operational flow, then how can you begin to know where to put AI? So you got to know what the AI capability is, what the issues are, and then you got to know where to put it, right? So the best places where I found in our system where we are able to effectively deploy artificial intelligence is if we actually know what's actually going on. And I say this because a lot of clinicians, whether you're a doctor, you're a nurse, or a pharmacist, we tend to work in silos. We think of our own process or that patient or that thing in front of us. We are creating in this society an ecosystem of healthcare delivery. Ecosystem. That ecosystem, whether we know it or not, is being created around us. How do I know? Because we have patients now, before they come to the doctor, who have already looked everything up on ChatGPT. That is now the ecosystem, okay? So we have to understand that operational flow. there's something called the human spotter, right? So it's kind of like you're doing gymnastics, right? Or you're lifting weights. Not me, but it's people out there who lift lots of weights, right? You wouldn't put 200 pounds to bench press without a spotter, right? So the 200-pound gorilla right now is AI. Right? So who's the spotter? Okay, so where does that spotter come in, right? So when you can't lift that weight or the AI makes a mistake, is there a spotter? So where is that human spotter? So that begs the question, where's the ROI, right? Because if you got to have a human spotter, then is the AI kind of worth it? Or is this part of the growing pain, a larger ecosystem of growing pain? With every technology deployment that I've been involved with, at least, you have to spend a little bit to get a little bit, and that's where we're at right now. Usefulness, does it make sense? Safety, that's pretty obvious. I put in ROI and added the word value because sometimes there isn't an ROI, and I hate to burst everyone's bubble, but there isn't an ROI sometimes. It just makes sense, and it provides lots of value. The doctors, recruitment, retention, it's all better. Adaptability and flexibility. If I buy this AI machine right now, is it going to be able to adapt to, I don't know, when a pandemic comes? Will it understand? When there's a fire? When I have, some other things going on with my workforce, which I shall not say, coming from Kaiser Permanente right now. And then is it reliable, right? So how do I know, or do I have to pay someone to constantly watch it? How many of you watch The Matrix, right? The Matrix? And you have this big screen and you have someone sitting there looking at these lines of code. Like, do I really have to pay someone to watch AI like that? Or is it going to be reliable enough, or are there going to be detection systems, right? And is it trackable? All right, so that's the answer. Believe it or not, I came up with this quickly, A, because I ran out of time, I fully admit, and B, this is actually what I think about. When people come to me and they say, I have an AI project, Kang, do you want to do it? And I go, well, this is what I'm thinking about here, okay? So that's the kind of the boring part. Let's talk about what we've done. So Abridge 2025, I'm not endorsing Abridge. That's just the ambient listening tool that we've used. Since 2024, which is exactly 2 years ago, we have had over 7 million recordings. We've deployed this to 7,293 provisioned accounts. So there are 2,800 doctors that are really, really resistant in our system right now. And of those 7,000, we have 64% that are actively using it, and there are 26 new enhancements coming. And we've even spread to surgical fields, okay? So you might be thinking, wow. The issue is that not everyone uses it every time, and it was really hard to get there. So how did we actually get there, right? We knew where to put it in the operational flow. We knew, how to get it so that so we had to get everyone a phone, because you had to speak through the phone. You couldn't use a microphone in the office because there were security reasons around that, people logging on and off. So the reason why it took us a long time, because in order to use Abridge, we had to get everyone an iPhone. You see how that works? So it isn't just the Abridge, now you gotta get everyone an iPhone. And then you gotta make sure that there's enough Wi-Fi in every building so that there's a good connection, okay? So all these dependencies. There's a human spotter in the system. Every node has to be reviewed. It was useful, it's safe because the doctor's reviewing it, et cetera, et cetera, et cetera. So what we learned from Shiv Rao, the CEO of Abridge, which we learned ourselves, is one of the most useful things that happens with Abridge is that once you train someone on Abridge, you have to make them use it 5 times that first week. Okay, change management. If you don't force utilization of this tool 5 times that first week, people will never touch it again, okay? They will not touch it again. So, but if you make people do it 5 times that first week, then all of a sudden your utilization goes up and people start saying things like, I could not live without this, okay? True statement. And I have had doctors who've basically said, I'm gonna work a little bit longer now, okay? I'm gonna stay. Now the value, going back to the ROI, isn't that you can do that, that they're working longer. The value is that you don't have to train a new doctor. Okay. The second thing is automations. All these are automations that we're currently doing within Kaiser Permanente. POE stands for Proactive Office Encounter, or preventative care. So people with virtual visits, we're automatically sending them now alerts to do their pap smear, blood pressure checks. When people are referred for allergy, the left lower column, we're sending automated letters for labs if they haven't had these labs done, et cetera, et cetera. We're doing automated refill. That's the dermatology refill request. And we have a bunch of other stuff going on with automation. It's namely that one down on the far right, which is normal labs. People are getting notified that their labs are normal with a letter, and it's being taken out of physician in baskets to reduce administrative burden. So that's actually happening. Now, this is the exciting one, okay? So I'm just gonna stop here. How many doctors like getting emails? Right? How many staff like getting emails? We get a ton of emails. So here's the current process. The current process is patient goes online, and this happens everywhere. They send doctors an email. At best, there will be categories. Is it about medication, other, referral? You choose a category, right? So there are rigid choices. And that's always reliable. Patients always choose the right category, right? So you know what I'm talking about. So this goes to a nurse who goes, it's 5 p.m. and this person actually had chest pain. And it sat there the whole day. Like, what do I do, right? Because the patient chose refills. The message is, I need a refill on my nitroglycerin because I'm having active chest pain, right? And they chose refill. They wanted a refill, right? So what did we do? So the future is actually now. So we've actually built in-house our own large language model that will read patient emails, okay, their actual intent, and classify them. So we're not relying upon the patient. We've built our own large language model to now, and we call it the smart messaging tool that actually reads the patient's email and classifies it, okay? Now, here's the kicker. Every specialty speaks a different language. Trust me, I'm a doctor, okay? Dermatology, primary care, surgery, blah, 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 right? So if I say I'm sneezing, primary care may not care, but allergy maybe go like, hey, that's important, right? So the bottom line is that these large language models are built specifically for that department, okay? So that clinical department. And on top of that, we built it for the operations. So if you have an acne clinic, it will pull it out, say acne, and actually send it to the acne nurse. Okay, so that's actually live in production. So anyway, so I thought it was cool, and if you want to read more about it, it's in JAMA. It just got published about 3 weeks ago. So I think it's the first of its kind, but we are now beginning to do that. And quite literally, I know something is good because everyone wants it. So, and all the departments are asking for it. So, all right, that's it. Thank you.
Hi, my name is Fawad Butt, and I don't have a lot of content on the slide, so I'm going to do a lot of talking. I'm sure you're all disappointed by that. Just to contextualize a little bit, I am the CEO of a startup called Penguin AI. Our moniker is born to solve the $1 trillion a year in admin cost. There was a panel on that earlier, so I was itching to make some comments once I got up here. So I intend to sprinkle some thoughts on the previous conversation as well. But before I decided, much to my wife's chagrin, to start a company, I actually had real jobs. And I used to be the chief data officer at Optum. I heard that come up earlier. I used to be the chief data and analytics officer at United Healthcare before that. I know that came up a couple of times today. And then before that, I was the chief data officer at Kaiser Permanente. So I've spent a lot of my time and career managing the data and analytics and AI capabilities across large healthcare in the US. At one point, I don't think I can make this claim anymore, but at one point, my teams had touched 70% of healthcare data in the US. Either cleaned it or massaged it or used it for a variety of purposes. So the experience I bring is both from large healthcare and also now from a startup standpoint. And there are a few things I'd like to say about the macro environment right now. I think there's a big shift happening. Everybody knows about this. The AI thing is here. But I think the adoption is happening very unevenly. As an entrepreneur who's talking to both health systems as well as payers, I can tell you there's a disconnect, as it was mentioned before. The providers started to adopt AI a little quicker. I think in first and second quarter of 2025, they realized that the payers were, for the first time in 20 years, behind the 8 ball, and they could upcode a lot, or they could appeal every claim that was denied, and there was a high probability that that would get overturned, and they've been doing that. And I think that that's definitely happening. The payers are obviously in the business of making money. They do that better than most other entities in healthcare, so they're not happy about this. They're definitely seeing all of this hit their P&L, and this is going to be a tough year for payers, as was last year. Medical loss ratios are through the roof. When I was at United Healthcare, the numbers were pretty simple. You spend, for every dollar in premium that you got into the system, you typically spend 79 cents on care. On a bad year, it would be 80 cents. And then the admin costs for us internally were somewhere around 14 cents. So you were, 93, 94 cents out of the dollar on spend, and then you had 6% margin, and life was great, and your stock went up every quarter. And but that's just not the case anymore. COVID really changed everything for us, and a lot of the care was delayed. And now if you look at the medical loss ratios, which is how much of a dollar is being spent on actual care, that number could, for some populations like the Medicare population, in some cases, that's 91 cents. That's gone up by 10 cents. And then there's been this thing called inflation that's been happening for the last few years. So your operating costs have gone up from 14 cents to 16 and 17. You do the math really quickly, you're on the wrong side of the equation. You're not making any money, you're losing a lot of money. So we're gonna see a lot of that. So that's the background and the context, right? There's a lot of pressure on payers, there's a lot of pressures on providers, the Medicare programs are flat, the Medicaid programs are being cut. There's just a lot happening in the industry that would typically compel these entities to come in and start to drive and adopt new things. But that's not really happening fast. And I think there's a little bit of a freezing mechanism happening at medium to large size enterprises in healthcare. And I think it's because the shift that they have to make is quite large, right? So the shift that's happening that I see is that we've built this healthcare world on faxes and human-driven applications, right? The applications where you hit next, and then you add some more information, and then you hit next again, and then it does something for you, and then you pass it to your other colleague, and they hit next. And so essentially that's the world we've lived in. And now all of a sudden, all this technology is available, and there's this whole concept of agentic AI. And agents are different than applications, right? Agents are able to access data, they have access to tools, they have some autonomy, they can make some decisions. And so if you step back, if you're a CIO or a CEO or a CDO or a CXO at any one of these organizations, you're looking at your enterprise and saying, I have 1,000 applications that are running. That means I may have to build 1,000 new agents to replace them, right? So, and that's a lot. There's a lot of confusion on where to start. The CEOs, I say, the CXOs are freaking out. They really are, and they have to make decisions. How do we go about building 1,000 agents? Do we just go buy 1,000 best-of-breed agents? One for each category, or do we buy a platform? Do we build our own models? Do we use our third-party models? If we're going to go to a platform, do we go to a generic platform like AWS or GCP, or do we go to a healthcare-specific platform? And there's a lot of decisions that need to be made, and I think that's really slowing down. That's really slowing down the decision making. But then there are other problems beyond macro problems, right? Like, turn something off. There we go. And so starting with standards, like we were told for the longest time that healthcare has standards and therefore everything will work interoperably. And now that right, exactly. So somebody said earlier in the previous panel, I think there was a question, somebody's like, why can't Kaiser do this? Kaiser's got a single EHR and one health plan and they should be able to do that. Let me tell you, I was at Kaiser. They do not have a single health plan. They have a health plan per state that they operate in. They don't have a single EHR. They have an EHR for every region that exists. In some cases, there might be 7 or 8 of them within one region. And so it's not that easy. The fragmentation is quite real, even within players that are represented to be best of breed. And so those are real challenges. The technologies also are very old. I would say the average tech stack within healthcare is 14, 15 years old. I mean, that's when the first time they bought it. Then they may have upgraded a couple of times along the way, but it's really not new. So the legacy is quite robust. And it doesn't need to be said, but I'll say it again. We're a very document-centric world, which that really means is that we're a very fact-centric world, right? And there was some conversation about why can't we just get rid of faxes? And I can tell you why we can't get rid of faxes, because the entire front office staff at half of US healthcare would quit. They really would. I've been in situations where we had better solutions than faxes, and the front office team that have been doing this stuff on faxes for 18 years just didn't want to learn the new stuff. It's a lot harder for them. Are you gonna get rid of somebody that's been there for 20 years and knows every nuance of your business? That's not gonna happen. So they drive a lot of the decisions. There's a lot more beyond technology that I think is part of the problem. Okay, I keep going the wrong way. The right one? There we go. The second is that there's a point solutions jungle out there, right? When I say there are 1,000 applications at a provider, I may be undercounting it by 1,000. And it's not that there's so many applications. Applications are applications. The problem is that any one workflow, you take prior authorization, you take patient onboarding, you take whichever one, there might be 5 or 6 different applications underpinning that single workflow, which just creates so much more complexity. The data, has to be sort of stitched through multiple applications. And the bigger problem are the people. So if you have 6 applications underpinning a single workflow, that means you have 6 application owners, you have 6 engineering teams and support teams doing that. And that creates a tremendous amount of conflict. And that is one of the things that's really slowing down adoption as we see it today. Just if that wasn't bad enough, we have this new AI thing, right? So we just talked about it. There's so many decisions that have to be made that people are freezing up, but then there are other decisions that also have to be made, which are macro. Who owns the budget for AI in a payer or in a provider? You ask 10 different systems, they'll give you 11 different answers. Who should make the decisions? What's the governance structure? Just all of these things are really not clear yet. So organizations and large organizations don't move until a lot of these bigger decisions are made. And I think in many ways, those are being decided. The CTO is fighting for the budget. The CDO thinks they should have the budget. The chief AI officer thinks he should be hired or she should be hired to be the chief AI officer. And I think there's a lot of transition happening on just leadership, and that decision making is sort of creating a lot of problems. The other problem is that AI doesn't run on magic. AI runs on data. And the data is not that great because of all the challenges that we've talked about there. It's not in one system. So my favorite and least favorite example are the same, which is provider data. This current state of provider data in the US healthcare system is dismal at best, right? So, and without naming names, some of the largest healthcare entities that I've worked at, their provider data, which means for those of you that don't know the full extent of provider data could be 120, 150 attributes of information. That'll include things like their name, their demographic information. It'll include their specialty, their credentialing, their locations that they can operate at. And you would think that's pretty easy to bring together. Why can't we do that? Well, the problem is that the name and the address is in the HR system. The specialty information is in some other system. The NPIs are in 2 other systems. The location information is in scheduling, which is 3 other systems. So by the time you try to bring all these pieces of data together, it's very, very complicated, and AI needs a lot of this data together. And I think that's also something that we're seeing, and it's actually adding to the cost of deployment. What we see is that we've never met a customer who thought their data was bad. We've never met a customer who didn't think they had all the data in one place. They will show me, hey, we spent $100 million on this big data transformation project. It should all be in Snowflake. Well, it isn't. So and if it is, then it's really all in the wrong formats. So the last thing I would say is that I think what was said earlier is that workflows really matter. I think in the world of AI, and as we think about agents beyond applications, we really need to start thinking about workflows instead of distinct pieces of work, but end-to-end workflows. And what we're seeing is that most organizations don't have a good handle on their workflows. They don't know. If you ask an organization, well, what's your onboarding workflow to bring in a new patient? I don't think it's ever been documented. There might be some person that maybe has some clue, but most people have no real idea. And that's a problem, because with AI, you can solve the workflow end to end, but you have to know the current workflow to be able to solve for it. And that continues to be a big problem. The second issue is there's a lot of conversation on ROI. How do we show ROI for AI? How do we show that it does deliver value? Well, for me to be able to show you value, we need to first know your current process and the cost of your current process and the impacts of your current process. If you don't have that documented, what's my baseline to show you value from? And so that tends to be a little bit of a challenging environment. The last thing I would say is that there's a thinking change that has to happen. We have application owners today. We have data owners. We don't have workflow owners in healthcare. In some cases, you might have a CMO that owns the UM team, and then the UM team owns the end-to-end UM workflow. But if you go to one layer down, you'll realize that intake is done by somebody else, and clinical review is done by somebody else, and decision communication is done by somebody else, and appeals are done by somebody else. And so ultimately, while there might be a department that manages multiple aspects of that workflow, there's really not a single owner for that workflow in terms of being able to make those decisions. And that is a challenge that we see with customer adoption as we go into the industry. So I didn't really mean to depress you with all the bad news, but they did ask me to tell you how it is really in the industry, and this is kind of where it stands right now. So thank you.
Well, great. So terrific to be here. Wow, what a great day. It's wonderful to hear just the substantive discussions, both in here and also out in the hall. And it's a privilege to be here. I'd like to just underscore a couple things before I jump in. I think if you're hearing one big message cutting across both of the previous talks, actually all three, is that workflow really matters. I don't know if you've heard that a few times, but I just want to underscore what that means. It means that actually the implications that the people that understand how things actually work become much more valuable. And I just want to point out that that's actually not how organizations are built. That's not how authority works in organizations. The people that are probably usually in the highest levels of authority least understand how workflows operate, with present company excluded. And seriously, I mean, you're hearing actually what is important in that discussion. And so, I think it's just actually for those with young at heart and with growth mindsets, it's a really interesting time for different types of talent to show up and bring a lot of value into the discussion. So there's AI or not, there's some good news there. So really briefly, whoops, I'm going all over the place here. A quick note on Peterson. So Peterson Center on Healthcare and Health Technology Institute is a nonprofit philanthropy, and it's part of the Peterson Foundation, Peter G. Peterson Foundation, and which focuses on monetary and economic policy. And so at some point 10 years ago, in the context of this larger economic focus, there was a recognition that healthcare drives our economic future. It's the largest driver of debt. It's a huge source of major impact at the household level in terms of affordability. And so the Center on Healthcare was stood up 10 years ago to focus on cost, affordability, and outcomes. And Health Technology Institute was stood up 3 or 4 years ago because there was a recognition that healthcare as a sector is doing something slightly bizarre when it comes to technology purchasing. It actually increases prices and does not expand access in general. And so that's an unusual behavior for how technology diffuses in this sector. And we've become very interested in how does the sector buy technology? And so that's a little bit of a macro theme that we'll jump into, and AI is, of course, talk of the town. So the unit of work that PHTI does, and so in that context, I lead strategic initiatives across the Peterson entities. What we do is 3 parts. One is that we do rigorous independent assessments of on-market commercial technologies, and we ask 3 questions. Does it work? Is it worth it? And for whom? And that's it. And so in that context, we ask questions like, for example, are the leading solutions for diabetes management on market, do they work? It seems like an obvious question, but actually, we don't have, like in biotech or biopharma, when we have a functional FDA, they do ask questions like, does it work? And so in that context, digital health doesn't necessarily have the same sort of structures around it. And so in this context, what we've tried to do is to say, does it work? And start to put out a signal to purchasers across the sector and say that you should understand that, what Peterson will do is invest a lot of effort into figuring out, does a category of solutions work? And then we do a budget impact analysis. And so we say, what is this going to cost and what are you going to get out of it in time cycles in healthcare that are relevant? So not 10-year windows, not 15-year windows. How long do people stay on plans on average? About 2 years. When you're thinking about healthcare budget cycles, provider cycles, how long do you think ahead? Maybe a year or 2, right? If that. And so these are the type of cycles that we think about budgeting. So that's a bit of what we do. And so in that context, we basically look at clinical areas of impact, so technologies that impact diabetes, musculoskeletal care, hypertension, et cetera, and you can go to phti.org and see these assessments. And increasingly, we're going to be focused on administrative technologies. And AI kind of sits in that ambit. We do these formal assessments, and then we also do what I'd call early market work and market shaping work. And that's what I'm going to talk more about today, because we haven't done major assessments yet in healthcare. So what we did about last year, just to give you a quick context, is that we brought together purchasers of AI technologies last year, provider groups in particular, health systems, and said, what are you buying? And everybody said the same thing. They're buying AI scribes. And so we basically said, well, based upon what you're buying, how are you buying it? Are you buying it per seat? What do you expect to happen? What are you seeing, et cetera, et cetera? And our basic view coming out of that, and we put out kind of a market trend report, was basically saying that actually clinicians really like it when they use it, a lot, actually, and that it's unlikely to have, I'd say, a classic productivity gain, and it probably doesn't save on net very much time. And you kind of put it this way, if you got 2 minutes or 3 minutes at the end of every Zoom meeting, does that mean that you get an extra 3 weeks of vacation at the end of the year? It doesn't. And so it's a big challenge in there about refactoring workflows to say, what do you harvest out of this? And so, that's a little bit of the early work we did, but we really focus now on, and what I'll talk more about today, is kind of what's happening on the vanguard of these technologies that's reshaping policy and market environments. And so I want to talk about that today. We'll leave the here and now to the experts, but talk a little bit about not the distant future, but actually what are technologies forcing both policymakers as well as folks in market to think about that they maybe wouldn't have had on their agenda. So we've kind of had three workshops, and we work with all administrations, this one extensively included, and to basically look at questions about how they are looking at policy decisions or regulation. And regulation is not the way that, especially this administration, frames it, but effectively, like, what does market shaping look like in this context? And so we look at kind of like what is happening in clinical AI, and I'll want to talk about that more this moment. We heard a little bit about administrative AI, and then this spring we're going to be bringing together folks to think much more about payments. So how do payments have to change, et cetera? And that's something that CMS has asked us to look at, in much more depth. So I'm going to spend a bit of time on clinical AI and say, let me give you kind of two examples that when we held this workshop, I don't know, last October, we thought that at least the autonomous hypertension management segment would be like a little far out. But by the time it's going to come, the report was released, I think yesterday, we already have seen work in Utah and other areas where kind of medication management in early forms is already starting to be kind of put into autonomous modes. So, you think you're early and then you're late, and that's the nature of AI work. So we brought together a number of folks across, the domains that had some understanding of clinical AI, FDA, CMS, folks across HHS and DOJ, people in healthcare system leadership positions and some payers, and basically said, like, look, what is the actual state of the technology? That's what we follow at PHTI. What can you actually do when it comes to like autonomous management of kind of chronic conditions like hypertension? And like, what will it mean when people start experimenting with this? What does it mean for permissions, guardrails, et cetera, payments, incentives, not putting incentives in there, et cetera? And so that's what we wanted to kind of come together to discuss. Because here's the point. If all of this looks like it's a little bit like either roughshod or cowboy-like in how it rolls out, market confidence and it will be understandably low. If there are real dividends from these technologies and people don't feel like they've gone through a strong process of being looked at, there's an evidence base building around them. People have tried them. They have parameters. There's levels of how they are operating that have kind of cleared the bar and gone to the next level. Then I think we're all going to be very concerned about the clinical environment we're in. So it is important to kind of start to put forward rules of the road, start to understand a little bit about what would be necessary to build confidence as these technologies, which are increasingly capable, are rolled out. So here's just like a little bit, it's like a detailed screen, but just to give you some sense, where are we now with a topic like autonomous hypertension management? I think like where we are now, and just to give you some sense of what do we mean by that, you have the ability to kind of read blood, what's on your blood pressure cup and set parameters like, is it high or low? We've had that for a long time. You have AI that can look at readings and make recommendations to people. What should you do? And then you can take that under consideration. That's already here. And then you have kind of more autonomous modes where, given the parameters at home, maybe you should ask the patient to double their medication, cut their dose, cut their pill in half, take 2, go to the doctor, right? So there's all sorts of modes that are not that far away in terms of infrastructure where you could be receiving guidance. Should you? It's a different question. Can you? We can. Then there's kind of full autonomy where you have things guiding parameters, looking at blood pressure readings and kind of adjusting and titrating along the way to goal. And, we do not have anything that's currently FDA cleared to do that, although I will tell you that there are a number, I'd say at least 6 or 7 entities right now that have the technologies to do these sort of things. So they're not very far-fetched in terms of can you, should you, how would you do it? How would you do it safely? What are the parameters? Those are the questions. And to give you kind of just some sense of what would you need from a workflow point of view to be able to do these things? You need to have some degree of bringing in data. We heard a little bit about data being a little bit of a mess. But, you would have to have data coming in terms of like home BP data, monitoring data, medical records. You have to be able to analyze it. You have to have some decision-making capacity. And then you have to understand what sections will you allow to become autonomous? What parts of the workflow? In all of this, what you see is that people are thinking. in great detail about all the steps inside, getting somebody to be managed well. And for all of you that are clinicians in the room, you will understand that something that sounds as simple as hypertension management may not be simple at all if it goes poorly. You can have people that have blood pressure that drops significantly. People misread things. All sorts of things happen normally. And so it's just something to understand that there's a lot in here, but if there was kind of like a tight use case, 1 in 2 Americans have hypertension, this is probably one area where it would begin. Just switching a little bit of topics, and I want to come back to some general principles, is that I think everybody's been aware that, mental health chatbots have been on the mind of Americans, over this last year. But here's the reality, people are already using them. It's not a question of can you, should you, it's happening at scale, millions of people. And so, this is one of those things where actually both market and policy and discourse in clinical medicine trails behind what it is that people are doing today. And so part of what we're thinking a little bit about is, what are these ways that we're kind of coming to? And I want to point out just this middle category, which is a slippery one. It's emotional support and wellness chatbots. All of that language is kind of tweaked around trying to skirt whether or not this is actually a medical device or whether or not it requires regulation. And you will notice that actually, a major American company that went into the UK left the market because the UK said, it doesn't matter what you call it, look at what it does. And this is a medical interaction. And so they kind of pulled out instead of having to go through the UK pathways. And so, but, of course, in the US, we have 1,000 flowers blooming at the moment. And so part of what we're doing is trying to understand what are the differentiation there? And what is it that you would need to do in terms of parts and pieces of building systems that are a bit more articulated, that have more steps and more capability? Because ultimately, we can say, fine, terrific, people have access to this. And by the way, PHTI has done a deep report on digitally enabled virtual mental health solutions, and actually they work pretty well. They actually work indiscernibly from actually a lot of human interactions. And so, it's a little bit where we're just asking ourselves questions about what do you need around these technologies to make them kind of interactive with the real world? When should you come in and out of their use? So just in this context, you can see that there's just, again, the same method, the same work that's taking place is to understand steps. And that's why I mentioned earlier workflow is so important. We have to understand the clinical steps here. And I think just what I want to kind of point out here is that there's a lot of work to be done to harden these technologies. How many people have heard of vibe coding, right? People have heard of vibe coding. It's very difficult to go from a vibe coded application into an industrial scale application. There's a lot of work to be done. I think similarly, just because we show proof of capability, what it takes to scale these capabilities across populations is an immense amount of work. And then you discover that there's lots and lots of important steps along the way. So part of what we have to do is to start actually naming these steps. But you only do that if you believe that we're going to have autonomous systems scaling across the country clinically, right? And so part of what we're trying to do is to say, let's not find out in 5 years that we should have thought about these steps because it is happening in certain places. Let's start to just say, hey, what would be required? And what are those steps? And can we understand if we're meeting the bar as we're going? Here's our bottom line on clinical AI. There's 4 general principles that we, feel are worth discussing. One is just that, I think in general, we have this strong sense, and I think it's a great point of debate for folks, that the evidence standards should compare AI to current standards of care and scale with clinical risk, but not idealized care. And this is your sort of well, what do you do in scenarios where people don't have access or workflows are poor or standards are low or error rates in human processes are high? And so you have to find the right comparator. At PHTI, we think a lot about evidence. And so a big part of it is actually understanding what's the right comparator. And so in this context, we just say, look, when you're looking at clinical AI, find the right comparator, and then be as rigorous and as direct as you need to be. 2, is that I think this is really important. The world of AI is full of like, I'd say like sandbagged benchmarks. There's lots of benchmarks that are like self-optimizing. That's actually how these technologies evolve. So it's like fine in the technology world, but it's not good enough for the clinical world. If you're not achieving results that are meaningful in the real world, then these technologies just sort of like pile up and they don't confer productivity benefits, they don't confer clinical benefits. And so we just need to understand what is the clinically native view of achieving a result. AI systems are not. 3 is that there was a lot of discussion about, well, should you be focused on AI systems just in low-risk populations? So kind of like step your way up versus high-risk populations. And I think like we generally felt like that's just, it's not a given that that should be your orientation. That's it. I'd say that it requires a lot of good thought. What about, I'd say like high-risk populations don't have access and also have the ability and want to interact, in this mode? There are lots of important discussions about second-class systems, autonomous systems, people getting different levels of care, et cetera, but it's a good discussion to have, and I think one that we should at least have with a little bit of open-mindedness about where and when we should drive, usage of these technologies. And then finally, my goodness, there are just so many questions about payments, about liability, about workforce displacement, about what am I gonna do, what is this gonna do? And so these, the sector is a human sector. We're gonna have to work through and take seriously these issues to gain confidence as we go through it. I wanna just cut to a little bit on administrative AI, just because there's been a thread today, and I will keep it brief. There has been, I think, like a lot of breathlessness about AI being able to improve the $1 trillion of administrative waste. And I'll just kind of like cut to it, which is to say that I don't think so. And so there's a lot of spend in there, so there's certainly good business to be built that do that. But net on net, like generally what we see today is that AI is inflationary. And let me just mention 2 things. One is that we've already seen, I'd say like the rise of like autonomous coding, which is another way of saying, scribe systems, et cetera. Like one of their main business drivers these days is to, in the term of art in the industry, is accurately code, right? And here's the tricky bit, by the way, and I don't say it cynically. It's to say that like we have an increasingly sick, older, and complex population. And so there is a world in which actually you're simply just coding and billing for the actual disease burden. It's possible. But the reality is it is inflationary. And so, there's a general sentiment that, the providers have won this round. I will tell you for any, provider in the room, they don't feel like it at all. But I will say that the response is coming. And the response is already well underway. And it comes in 2 ways. One is that you can just lower rates. If you see secular trend that kind of goes up on the provider side of what's being billed and it's clipping up by 8-10%, you can just lower rates. But and then the second is that this bot-on-bot interaction is real, and it's unfolding in ways that are going to be quite consumptive. And it's going to be like, oddly enough, costly to build that transaction infrastructure, and somebody's going to pay for it. And so, there's a lot of nuance in that discussion, and we have like, not enough time for it. But I wanted to just leave you with one kind of thing to think about. One that right now, like, it is like a weirdly, like, worthy thing to do to reduce the transaction costs in this sector. It sounds like an incredibly inspiring rallying cry to get people mobilized on the streets. But like, this is an expensive transaction environment in healthcare. And it shows up in your bills, and it shows up, and it takes money off of your wages. And so it's like an important problem to think about and to work on. A lot of the solutions that are coming out, and Fawad is certainly more the expert here, but are usually one side of an equation heavily. So they're either heavily payer-oriented or heavily provider-oriented. And that's what generates this sort of like, I was going to say itchy and scratchy sort of dynamic, but like basically, coming at each other, right? With better and better tools on either side. And like what's uncertain about all of this is like, what's the net impact of like all this work to digitize and to like go back and forth on these transactions? It's really unclear, but like it's not promising. The one thing that I have been hearing, which I'll just leave you with on this topic, that is interesting is that would healthcare providers accept lower rates to remove this transaction infrastructure? Would you take 10% discount on net billing to get rid of it all? And yeah, you hear yes, and it turns out that people are saying yes. And so, there's like really interesting questions in here, which I will leave you with this, which is that like there are lots of frictions and you're gonna have lots of market actors on the AI side solving little parts of these processes. And they're gonna address your near-term pain. And so you're gonna say like, yeah, that makes sense, I need that. I need somebody to like digitize eligibility because that's a big source of claims denials. Makes sense, makes sense. And then you're gonna kind of come to a wave 2 of solutions that says, my goodness, like, shouldn't we just be redesigning these interactions? And sometimes that's going to be, that's actually what Nikhil earlier said, like these between interactions. And like, we're starting to see a little bit of that. You see a Bridge and Highmark trying to like redesign interactions with other payers. But I think underneath it all, like what this is doing is it's accelerating the back and forth in this system, and it's raising just basic questions about like how do we design these big workflows in the sector? Like what are we trying to accomplish? And I think that we actually are in this like interesting moment where even the folks on the regulatory and leadership side are really listening hard for what is it they could do. They're saying like, what is it? Like name the things, name the standards, et cetera. If you're real geeks on this topic, you'll have been following Da Vinci standards. How many people have been following Da Vinci standards? Okay. It's like really exciting stuff. And so it's basically, it's digitized standards for some of these transactions. And if you actually talk to people that deal with these Da Vinci standards, is that it turns out you can follow the letter of the law for policy standards and still make it impossible to work with the outputs. And there's a lot of actors out there that are highly incented to like not make standards execute properly. And so I just want to point out that like you hit these jams, like these human jams, because people have strong incentives to generate these jams. And so you have to kind of ask about these bypasses. And like, that's why I mentioned this 10% discount for, skipping parts of the system, right? And so at any rate, like, I just say that like AI is a terrific conversation starter. It's so very interesting. It also accelerates dynamics, and then it kind of leads you to ask like basic questions of like, what are we trying to do? And so I hope that what you leave here with is like a promising, interesting, good news possible story on clinical AI. There's a lot of interesting things to do. And then, I hope that you like think a bit more blue sky and feel permission to do so about administrative systems and like what are we trying to accomplish with them. And that's that. We have more to come out of PHTI. Thank you.
Hello?
I think they're done for the day.
So I think you set me up for my first question, which I'm, I think incentives are set up in such a way that I think the bad outcomes can definitely grow. Bad outcomes will grow faster. Dr. Nguyen, before our panel today, you said if you want a bad problem to grow faster, use AI. And so I'm wondering like what needs to be in place to produce the positive sort of system or organizational impact that we want to see in the world? And Fawad, I also want to give you a chance to respond to some of the.
I've got lots to say, but I'm gonna hold that.
I'll maybe just give a macro answer and then you'll hear a real answer, which is, like, it makes sense that in a room of like both policy and business experts, we'll spend a lot of time on incentives. But like, if you just like think about like, there's like a topic statement and then there's like a subtab and there's a subtab, and the subtab is incentives, because incentives are meant to kind of sustain behaviors or to shift behaviors. And you are trying to pursue those shifts or sustainment in behaviors because you have some clear set of goals. Like, what are you trying to accomplish? And I think that like, it's very easy to like say like, we need to fix the incentives and then forget that we have like top level goals that are worth pursuing. And I mention that just because like in serious rooms like this, we don't always give ourselves permission to say like, hey, what are we trying to accomplish with prior auth, for instance? Like it's a complicated issue. It's not facile, but there is opportunity sometimes where you have multiple actors that are willing to say like, all right, maybe there's bypasses, maybe there's other approaches. And then you can then start to say, okay, what are the incentives to shift attention to, really different approaches? And so I just want to kind of come back to it and say like, when you're inside a system that's trying to sustain or change behavior, incentives are so important, kind of drive it. But then if you're sitting at a moment like this, where like so much is in flux, you have to just ask yourself, like, is that the right level of detail to dive into? The real answer.
I would just say very practically, and to what you just said there, really identifying what the pain points are, the problems that you're solving for people who are using it. And it leads to something called basically having people then trust the system. So building things that actually will ensure that they can actually trust the tool that they're actually using, and that's how you speed this all up, at least from the utilization side.
Great. We have 5 minutes left, so I want to see if we have questions from the audience. We have one up here. Is there anyone up there?
Thank you for your presentation. What I got from it is that we need to maybe go slower and have a thoughtful process, and we just can't, just because things work, we shouldn't jump into it. But what's happening in real time, because we're running out of primary care doctors, is that two things have happened in the last couple of weeks. That in Utah, they're letting AI fill prescriptions, and in Massachusetts, they've run out of primary care doctors, and almost every health plan is now using AI as the front line for new patients. Should we be worried about this, or are we going to see this invention play out and just go 2 steps forward and 3 steps backward? But it seems to be going into the marketplace out of necessity, maybe ahead of schedule.
I'll kind of answer that because I am a family physician, and I will tell you that parts of the AI that I think will really help out is basically data collection. So rather than having a patient come into my office and spending lots of time with me asking what's your history, past surgical history and so forth, having the AI do that ahead of time will actually help to speed me up. So I think the tools that will help out are those that augment the experience and not replace the experience. And so I think for twofold: number one is it helps the physician out in the clinic itself, and number two, it actually makes it a career worth having, that you're not becoming a tool to just basically collect data and then not have time to actually think about it. So for example, for Abridge, I always say what it has done is basically it's humanized the experience again. It's returned the joy to medicine. That's how you get people back into primary care.
Yeah, I'd say I think the data speaks for itself, right? What do you think is the average age of a U.S. physician right now? Right? It's close to 60 years. I think it's 59 and a half. You go by specialty and you see numbers like 62, 64 in some cases. So, and the total population of practicing physicians has gone down from 1.3 million to 980,000 in just the last decade alone. So the reality of the matter is that we need support. The physicians need support. The process, the system needs support. And where I disagree with my colleague on admin is because I see the impact on admin. I'll tell you, there are physicians that are not delivering care. There are tens of thousands of physicians that work for payers, insurance companies, and all they do is review prior auth requests or look at claims and appeals. Tens of thousands of these people, and nurses even in larger numbers, and pharmacists and so forth. In a world where we have capacity constraints on these people that could actually be delivering care and care coordination, we shouldn't be deploying them on admin tasks like that. And we see the numbers, right? The average orthopedic case that is for a person above the age of 65 or 67 is 47 minutes of a clinician's time to review for a prior auth request. You use an AI tool to automate some of the review and the recommendations, that goes down to 6.5 minutes. So I see the impact of AI in places where physicians and clinical staff are in general being used as report readers, and really shifting that focus and that time back towards care delivery. So I think it's a real necessity. It's not even an option. Just the numbers speak for themselves.
Yeah, I mean, first of all, just to compliment a couple comments are like three things that kind of blow my mind about just the sheer numbers or dimensions of this. You know, one is that Rachel Walensky in a New England Journal article about workforce said that between the last generation of doctors and the current, with the same numbers, the current generation practices 50% less hours. And you hear this from older doctors, right? Younger doctors don't practice as much. The reality is that net capacity has gone down 50%, just generationally. That's one. Two is that of those doctors, there's a 10% year-on-year attrition from areas like primary care. In the wake of that, you see the rise of other professions. So nurse practitioners have gone from 8% of ambulatory visits in the early aughts to they're going to be 50% of 1 billion visits in the early 30s. 60% of them are trained online, mostly. And so in this context, like we have a real mix of workforce shifts entering in here. And the sources of capacity are going to be more varied. So there's going to be a mix of all these answers. There's going to be doctors, there's going to be NPs, there's going to be non-physicians, there's going to be augmented folks, there's going to be triaged out things that are directly automated. And this is just the capacity question. And I like to just ask, like, I'm a primary care doctor. I would like a lot more emphasis on supporting primary care doctors. And I will also tell you that it will never add up to the capacity we need. And so it's a time for thinking creatively about it.
Thank you, everyone. So that's the time that we have. Can everyone join me in thanking our panelists for today?